The following podcast is part of a certified educational activity titled New Frontiers in Managing Heart Failure. Are SGLT2 inhibitors the next leap forward in optimizing patient care? Access the entire activity and complete the post-test at peerview.com/ZAZ860. Downloadable infographics and additional resources are also available.
Hello, this is Dr. Javed Butler from the University of Mississippi. Welcome to this infographic-based educational activity designed to explore the rationale for the current recommendation prioritizing SGLT2 inhibitors as a potential management strategy for patients with heart failure and type 2 diabetes. As part of this activity, we also discuss some of the trials currently underway investigating the use of SGLT2 inhibitors as heart failure treatment in patients with or without diabetes. The title of the presentation is New Frontiers in the Prevention and Treatment of Heart Failure. Are SGLT2 inhibitors the next leap forward in optimizing patient care? To put our presentation in perspective, let's talk a little bit about the guidelines and the current recommendations for management of patients with heart failure. Heart failure risk and stages are divided into stage A, B, C, and D. This is distinctly different than the symptomatic classification of patients who have prevalent heart failure, which we are all used to, which is New York Heart Association class 1, 2, 3, and 4 heart failure, depending on no symptoms, minimal, moderate, or severe symptoms. This is a little bit of a different construct. We are not talking about symptomatically classifying patients with heart failure, but we are actually looking across the spectrum of risk for heart failure. So stage A is defined as patients who are at risk for developing heart failure, but they don't have any structural heart disease. So these will be the patients, for instance, with hypertension or diabetes who have not developed a structural heart disease. Stage B are the patients who are at higher risk, a little bit of a heightened risk than even stage A patients. These are the patients who do not have symptomatic heart failure, but they have structural heart disease. They may have left ventricular hypertrophy or asymptomatic LV dysfunction, diastolic dysfunction. So these are all the patients who are now already showing signs of structural changes, but they don't have the syndrome of heart failure. So what are the guidelines right now by the American College of Cardiology, American Heart Association, Heart Failure Society of America, or the European Society of Cardiology in terms of management of these patients to reduce the risk of transition from a at-risk for heart failure population to patients who develop heart failure by themselves? The therapies that we utilize in these high-risk group are lipid-lowering therapy in patients at risk for coronary artery disease or other vascular diseases to reduce the risk of myocardial infarction. ACE inhibitors and angiotensin receptor blockers, beta blockers, thiazide-based diuretic therapy for management of hypertension. And then we have also data on RAS modulation in high-risk group of patients, for instance, from the HOPE trial. So this is sort of the spectrum of lipid-lowering therapies, ACE inhibitor, ARBs, beta blocker, diuretics, and lipid-lowering therapies in specific subpopulations of stage A and stage B patients that, when implemented, reduce the risk of development of heart failure. But what if you do develop heart failure? So now you are a patient with symptomatic heart failure, but not end-stage heart failure. So this is a stage C heart failure. What is the evidence for care of these patients? So let's divide this group into those patients who have symptomatic heart failure with reduced ejection fraction and symptomatic heart failure with preserved ejection fraction. From an epidemiologic perspective, if you take all patients with heart failure, the division of the two is roughly 50-50%. So both represent a significant population of heart failure patients, and both populations of patients have almost comparable adverse risk for mortality and hospitalization, functional capacity impairment, and quality of life reductions. Now, we have been very lucky over the past 3 decades to have had a series of therapies that have been shown to reduce the risk of morbidity and mortality in patients with heart failure, reduced ejection fraction, starting with RAS modulator trials with ACE inhibitors and ARBs, subsequently with trials with beta blockers, trials with mineralocorticoid receptor antagonists, and now latest trials with angiotensin receptor neprilysin inhibitor. All 4 classes have been shown to reduce the risk of mortality and morbidity in these patients. Obviously, in conjunction congested patients, we use diuretics for improvement in symptoms. And then in subpopulations of patients, those patients with persistent high rate, the use of ivabradine, and patients who are African American who have persistent class 3 and class 4 symptoms despite standard of care, the combination therapy with isosorbide dinitrate and hydralazine have also been shown to reduce the risk of mortality. So the glass half full is that there are many therapies that are available for the management of these patients. The glass half empty is that in these trials, even with these therapies, when implemented, there is significant residual risk that we need to improve. Now, if you look at stage D patients, so those patients who have transitioned from being stage C to really developing end-stage disease despite therapy with all of these effective medications that I discussed, there are other alternative options like left ventricular assist devices, mechanical support, or cardiac transplantations in patients who are eligible for it. But obviously, this is an advanced terminal disease, and in some patients, we have to be very cognizant in implementing palliative care earlier in the disease to manage not only their symptoms across the spectrum of disease, but also manage their end-of-life concerns. So there are clearly these data that have been generated in clinical trials have been very strongly endorsed by the guidelines as well. If you review the guidelines by the American College of Cardiology, American Heart Association, and the Heart Failure Society of America, they emphasize that the therapy, which is the base therapy, is RAS modulation and beta blocker use in conjunction with diuretic for treatment of congestion. After that, there are various different scenarios for medications like aldosterone antagonists and hydralazine nitrates and ivabradine based on renal function, heart rate, symptoms that we can use. But also remember, we are not only talking about drug-based therapy, but there are devices in specific populations of patients as well that have been shown to improve survival, like cardiac defibrillator or cardiac resynchronization therapy. Now, while we have been very successful in the treatment of patients with heart failure reduced ejection fraction, though there are plenty of opportunities in further improving outcome for that group, we have not been as successful in patients with heart failure and preserved ejection fraction. We do not have any conclusive trials that have been shown to improve morbidity and mortality in the long run. We do have some trials with mineralocorticoid receptor antagonists and angiotensin receptor blockers that have shown to reduce hospitalization risk in this patient, and there are class 2 recommendations for these two agents. The therapy is primarily either to congestion and diuretic use or targeted to comorbidity management like hypertension or diabetes or dyslipidemia, but there is a special correlation and focus on appropriate evaluation and treatment of ischemia and also atrial fibrillation and heart rate control. So plenty of opportunities to improve outcomes there as well, and hopefully some of the ongoing trials will help us. But management of comorbidities, management of congestion, and use of MRA and angiotensin receptor blockers are also recommended. So while there is a lot of evidence from different trials that show improvement in outcomes, and now they have been approved, they are available in the market, many of them for many years now. Many of these are even generic therapies, and they are class 1 recommendations by the guidelines. Two questions come up. One, do we need to use all of these medications in patients with heart failure reduced ejection fraction, or can we pick and choose one or the other? Is there incremental cumulative benefit? And then the second question is, how actually are we doing in the communities where we practice in terms of implementation of these therapies? So let me take both of these questions one by one. The first question, whether these therapies should be used cumulatively and is there incremental benefit to using them one on top of each other? And the answer is absolutely yes. There is no doubt. For one, because the way the trials were designed, these were designed on top of optimal medical therapy, so the benefit is incremental on top of each other. But even if you look at the real-world evidence from practice setting, one can see that while each of these classes of drugs individually is beneficial, the benefit is more in patients when they are taking all classes of drugs together, which has been shown for all-cause mortality in patients with heart failure reduced ejection fraction, that if you use a combination of RAS modulation and beta blockers and mineralocorticoid receptor antagonists all together as compared to placebo, you get more benefit as opposed to using two drugs at a time or only one. So using all of these agents is a good idea. Another important fact to realize is when to use these therapies. We know for a long time that once patients get hospitalized for decompensated heart failure or worsening heart failure, they are at a significantly higher risk for recurrent hospitalization. And the more the number of hospitalizations, the worse the risk, and there is almost a spiraling down in terms of their prognosis. So the best time to start these medications is when they are stable in the outpatient setting. Just think about it. This is what we do for all diseases, for hypertension, for diabetes, for dyslipidemia. We don't wait for people to get worse. We start them so that we can avoid people from getting worse. So it's the same thing that we should be thinking about in heart failure when they're stable in the outpatient setting. However, we should also be very cognizant of the fact that once they do get hospitalized, their risk significantly worsens from 3 to 4 times higher risk of mortality in the subsequent year. So we should really pause, relook at the patient's entire care, and wherever there are opportunities, we should optimize their medical therapy. The point that I made about using these therapies in concert for cumulative benefit and using all pathway modulation with RAS modulation and beta blockers and MRA and other therapies when needed is not only true for mortality, but is true for risk for hospitalizations as well. Now, while the data are pretty strong that these therapies are beneficial, the question is, are there any opportunities in terms of implementation of these data into clinical practice? Yes, there are a lot of opportunities, and perhaps we have not done as good a job in translating these therapies into clinical practice. There was a recent publication looking at over 3,500 patients, contemporary group of patients from 2015 to 2017 across 150 practice sites from cardiology and primary care settings in the United States. And the bottom line is that about 1 in 4 patients are not on RAS modulation, 1 in 3 patients are not on beta blockers, and almost 2 in 3 patients are not on mineralocorticoid receptor antagonists. So there's a lot of opportunities for improvement in care. And when we do implement the therapies, it turns out that for RAS modulation and beta blockers, about 50%, give or take, are patients who are on less than 50% of target doses. So I think there's plenty of opportunities for known therapies that have been shown to improve the outcomes for our patients. And as class 1 recommendation, there are plenty of opportunities for providing those prescriptions to the patients and increasing the dose as tolerated by the patients. And this is not only a U.S. issue. There was a global survey published from 36 countries from our European counterparts and showed similar data that there's a lot of opportunities for giving these therapies and giving them at appropriate doses, and the therapies were not being used at target doses. Now, while we are talking about heart failure in general, let's focus a little bit about diabetes and heart failure. It really doesn't matter once you develop heart failure in a patient with diabetes, whether you develop heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Both of these patients have a substantially higher risk. So that should be judged from a perspective of the fact that, one, patients with diabetes are at a higher risk of developing heart failure than those without diabetes. So any preventive strategies should be implemented even strongly, but also realize that not only patients with both HFrEF and HFpEF who have diabetes are at a higher risk, they are at a much higher risk for mortality than HFrEF or HFpEF patients who do not have diabetes. So aggressively treating patients with diabetes who have heart failure and trying to generate evidence is also crucially important. There was a very interesting study published from Sweden recently that showed that if one were to have optimal risk factors in terms of hemoglobin A1C control, blood pressure control, lipid control, albuminuria, and person is a non-smoker, your risk for atherosclerotic cardiovascular disease, myocardial infarction, stroke, and all-cause mortality is significantly attenuated. But despite of these risk factors being controlled, the risk for heart failure still was persistently high and was significantly high, about a 43% excess risk. So what this basically tells us that while atherosclerosis is clearly a risk factor, myocardial infarction and ischemic heart disease for heart failure are alternate pathways that also modulate the risk of developing heart failure in patients with diabetes that are not completely mitigated by traditional risk factors, and we have to go beyond traditional risk factor control. So to summarize, prevention of heart failure hospitalization and heart failure risk in patients with diabetes is really an acute need, that therapies that are better tolerated in patients with heart failure reduce ejection fraction, and newer therapies that can improve outcomes for patients with heart failure with preserved ejection fraction to further reduce morbidity and mortality and progression of disease in both of these groups of patients is an opportunity that requires further research and further evidence. But not only that, aggressive implementation of therapies that we already know improve outcome for these patients is also needed at a community level. So let's now talk about the rationale for considering SGLT2 inhibitors as a potential new prevention and treatment strategy for patients across all stages of heart failure. So if you think about the risk factor construct, most of the patients who develop heart failure actually tend to be multimorbid, and these risk factors tend to aggregate in these patients. Patients who have chronic kidney disease, type 2 diabetes, atherosclerotic cardiovascular disease, and heart failure tend to overlap. Many of these patients have a multitude of these comorbidities, and that is seen in the cardiovascular outcomes trials. There are several cardiovascular outcomes trials with SGLT2 inhibitors, EMPEREC trial, CANVAS trial, DECLARE trial, that does give us some idea about these multimorbid patient populations and what happened to their heart failure risk in terms of heart failure hospitalizations in those with and without heart failure at baseline. These are the data that have been now used by the guidelines to make some recommendations, which we can discuss, but also have guided the development of newer trials going forward. There is about 12 to 45% of type 2 diabetes patients who actually have heart failure. 14% of the US population actually have diabetes, so a huge pool of people. And of those, about 12 to 45% have heart failure, depending on which study and which population if you look at. But these numbers become staggering if one were to think about that 14% of the US population has diabetes. That overlap is about 1 in 3, or about 32% of type 2 diabetes have coronary artery disease, about 35 to 40% have chronic kidney disease. So you can imagine that if there are therapies that can benefit multiple organs, one can perhaps have benefit in terms of clinical outcomes that are modulated through multiple pathways as well. So what are the cardiovascular outcomes trials that have been done for which we know the data and perhaps some are ongoing? The first one to come out was the EMPEREC trial with empagliflozin, then canagliflozin with CANVAS and CANVAS-R trials, then DECLARE TIMI58 with dapagliflozin. And we will also see data with sotagliflozin in the SCORED trial and ertugliflozin with VERITAS trial. But we are in a position to be able to discuss at least data with EMPEREC, CANVAS, and DECLARE. While I will provide you with some numbers, please keep in mind that these are not comparable trials and comparable numbers because different kinds of patients were included in this trial. EMPEREC trial exclusively included people with type 2 diabetes who already had atherosclerotic cardiovascular disease, a history of stroke, peripheral vascular disease, coronary artery disease. CANVAS trial, about 2/3 of the patients were similar, but 1/3 of the patient had risk factors for atherosclerotic cardiovascular disease, but did not have clinically manifest cardiovascular disease, whereas DECLARE had the largest proportion of patients who actually did not have atherosclerotic disease, but were more of this so-called primary prevention cohort, which is patients who had risk factors for atherosclerosis, but did not have atherosclerotic cardiovascular disease. So along the spectrum, EMPEREC, all patients with atherosclerotic cardiovascular disease; CANVAS, majority with atherosclerotic cardiovascular disease, minority with risk factors; and DECLARE, the opposite, had the largest proportion of primary prevention population. So if you look at EMPEREC, there was a 14% reduction in MACE, which was statistically significant. In CANVAS, also 14% reduction in major adverse cardiovascular event, which was a composite of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. In DECLARE, the primary endpoint was a split primary endpoint. MACE, there was a 7% reduction, which was not statistically significant, but the second half of the primary endpoint was a composite of cardiovascular death and heart failure hospitalization, which was significantly reduced by 17%. But I would again highlight that we cannot compare these numbers across because different patient populations were enrolled. However, with our focus today on heart failure, what were the heart failure outcomes in this trial? Remember that the notion of primary prevention and secondary prevention based on whether you have risk factors for atherosclerosis or whether you already have atherosclerosis is a paradigm for atherosclerotic heart disease. But we already discussed that patients with diabetes may develop heart failure through alternate pathways as well, and therefore the primary and the secondary prevention concept may apply a little bit differently for heart failure benefit. And indeed, if you look across the three trials, the heart failure benefit was seen across the entire population. And not only was it seen across the entire population, it was robust. There was a 35% reduction in the risk for heart failure hospitalization in EMPEREC trial, 33% reduction in the Canvas-R program, and 27% reduction in the declared TIMI 58 program. Pretty substantial reduction in the risk of heart failure hospitalization. Well, because heart failure was neither an inclusion nor an exclusion criteria in these trials, there were about 15% of the patients who had history of heart failure who came into these trials, whereas about 80-85% did not have heart failure. So this heart failure hospitalization benefit that I just mentioned, was it only in those with heart failure or without heart failure, or was it seen in all groups of patients? And it turns out that in all the three trials, if you start looking at the subpopulation with respect to baseline history of heart failure or without heart failure, the heart failure hospitalization benefit relatively was seen in all the groups. Obviously, the absolute risk may differ because patients with heart failure are at a higher risk than those without heart failure. But nevertheless, the directionality and the proportionality of benefit was seen in both groups of patients. Well, I just mentioned to you that the risk for atherosclerotic benefit may be related to primary or secondary prevention for atherosclerosis. But what about heart failure hospitalization risk? Interestingly enough, if you look at patients who did have atherosclerotic cardiovascular disease versus those who did not have atherosclerotic cardiovascular disease but just risk for heart failure, as mentioned, the benefits for heart failure were seen in both groups of patients. But if you look at the cardiovascular death benefit, that was only limited to those patients in which there was atherosclerotic cardiovascular disease in the EMPEREC trial and in the Canvas trial. That was not shown in the DECLARE trial. But those patients who had risk factors, there was no cardiovascular death benefit. I have discussed a lot of pieces of data, but to summarize, the benefit for heart failure was seen across the spectrum, whereas the benefit of MACE was largely limited to those patients with history of atherosclerotic cardiovascular disease. If there are these heart failure benefits seen in patients with heart failure, the 15% or so that were included in these trials with heart failure, was the benefit in HFrEF patients or HFpEF patients? Well, recently some of the data have been published that I would like to go over, but please do realize that these trials were not designed to look at these questions, and this is a subgroup of the subgroup based on whatever retrospectively we could get the data on in terms of the patient's ejection fraction. We don't have these data in EMPEREC trial, but the investigators did go back and found the data whether there was documented heart failure with reduced ejection fraction in DECLARE and in Canvas trials. And in both trials, the patients, when you divide them with HFrEF versus heart failure patients who did not have HFrEF, and as you might imagine, did not have HFrEF, means either HFpEF or there was no ejection fraction known, just there was a diagnosis of heart failure. So those two were combined. It turns out that the benefit for mortality was significantly more in those with HFrEF, whereas hospitalization benefit was seen in both HFrEF and then HFpEF. So what it tells us that not only is there hospitalization benefit, but in HFrEF there may be mortality benefit, but I would highly caution not interpreting these data too much because these are subgroup of subgroup analysis. These are secondary analysis, and then ongoing research trials that I will talk about will answer these data for sure. But nevertheless, hospitalization benefit was seen in both HFrEF and HFpEF and those patients who did not have heart failure at baseline. So this plethora of data from 3 clinical trials and subgroup analysis has now been picked up by many guidelines and statements, the American Diabetes Association EASD 2018 Consensus Report, the American Diabetes Association Standards of Care document for 2019, the 2018 ACC, American College of Cardiology Expert Consensus Decision Pathway, and the ACCHA guideline on primary prevention. The bottom line is that those patients who have diabetes, who are either at risk for heart failure or have heart failure, there seems to be a reduction in the risk of heart failure hospitalization. And therefore, the guidelines suggest that in these groups of patients, that SGLT2 inhibitors should be considered after metformin as a therapy if their renal function is preserved. Also, remember that canagliflozin right now is indicated for MACE reduction in those with atherosclerotic cardiovascular disease and type 2 diabetes, and empagliflozin is indicated for reduction of cardiovascular mortality in that group. There is no SGLT2 inhibitor that is currently approved for either prevention of heart failure hospitalization or treatment of heart failure. These data are all forthcoming and will be looked at by the regulatory authorities, and we will learn more in the future. But the guidelines have stated that based on the cumulative evidence that patients who have type 2 diabetes and have heart failure, these therapies should be considered for the management of diabetes because you also have tolerability data and data in terms of management of heart failure. However, whether these are heart failure drugs or not, further clinical trials are needed. Do remember that there is some renal use criteria for these therapies. For example, with canagliflozin and empagliflozin, the use is restricted to 45, whereas with dapagliflozin and ertugliflozin, it is restricted to 30, but no new initiation less than 45 for DAPA and less than 60 for ertugliflozin. So just keep that in mind. However, there are some renal data forthcoming as well, and time will tell whether these thresholds in future will change. While we have been focusing a lot about benefit, we cannot forget about the potential for risk. Remember that there is a box warning for the risk of amputation lower extremity with canagliflozin. Across the spectrum of these SGLT2 inhibitors, female genital mycotic infection is a concern. And then there are also concerns related to urinary tract infection with empadepa and cana as well. So we need to keep those common adverse effects and box warning for amputation in mind as well. Contraindications also include serious hypersensitivity reaction and severe renal impairment, end-stage renal disease or dialysis, and caution related to bone fracture, osteoporosis, euglycemic ketoacidosis, genital mycotic infection, hypoglycemia, primarily if used in conjunction with insulin or secretagogue, are all the things that we need to be concerned about. The risk of amputation was heightened in those with prior history of amputation or severe peripheral vascular disease or active ulcers and infections. So all of these things have to be kept in mind. I did mention in the passing that these drugs are now given a preferential place in the guidelines for management of diabetes if you have heart failure or if you have risk for heart failure. But I also mentioned that these therapies may actually be not only beneficial in management of diabetes and risk for heart failure, but may actually be heart failure therapies by themselves. But why would one think that? And the reason for that is that if you look at the broad pharmacodynamic profile for these therapies, they have osmotic diuresis, they cause natriuresis, they lower blood pressure, weight loss, which also includes reduction in adiposity. And if you have adiposity reduction, you have decrease in inflammation and oxidative stress. It has been shown to reduce albuminuria and slow the progression of chronic kidney disease. It causes a mild level of ketogenesis, which may be a preferential energy source for the heart. There are data emerging for sodium hydrogen cotransporter inhibitor as well that has effect on intracytosolic calcium concentration, perhaps modulates the risk of certain cardiac death. Also data for endothelial function, sympathetic tone. If you look at the broader pharmacodynamic effect of these agents, it would suggest that these may be beneficial in cardiovascular diseases irrespective of diabetes. There are data in regression of left ventricular hypertrophy. There is a study going on with dapagliflozin called DAPA-LVH. But there's an alternate study that was actually recently presented called EMPAHEART that took about 97 patients and looked at the effect of empagliflozin in reduction in LV hypertrophy at 6 months. These were not heart failure patients. These were patients with type 2 diabetes and stable coronary artery disease and normal left ventricular ejection fraction. And basically, what we found was at the primary endpoint, there was a 2.6 gram per meter square reduction in LV mass with magnetic resonance imaging, which was significant. There were other benefits also in terms of reduction in blood pressure and a trend towards reduction in LV and systolic volume index. These were most seen in people with baseline LV mass of greater than 60 gram per meter square. So clearly, left ventricular hypertrophy reversal is also associated both with risk for heart failure development and improvement in outcomes. So while we do have some data in HFrEF and HFpEF that makes us feel that these therapies may be good in patients with heart failure, remember the cardiovascular outcomes trials with diabetes were not designed primarily to answer this question. We uniformly don't know patients' ejection fraction or natriuretic peptide level or adequacy of baseline care or symptomatology. So there are some limitations. But in order to overcome those limitations, now there are dedicated trials in heart failure with preserved and reduced ejection fraction ongoing, with dapagliflozin in both heart failure with preserved and reduced ejection fraction, with empagliflozin in reduced and preserved ejection fraction in the chronic outpatient setting, and with sotagliflozin in patients with worsening heart failure as well. These are all large outcomes trials, but one thing to highlight is that based on the pharmacodynamic profile that I just mentioned, these trials include patients with and without diabetes. So the focus here is not management of diabetes in heart failure patients, but irrespective of diabetes, do these therapies actually improve outcomes for patients with heart failure? So 5 large programs are going on, exciting times, and we will get a lot of data moving forward. So to summarize our discussion today, SGLT2 inhibitors are prioritized for second-line use after metformin in patients with type 2 diabetes with or at risk for heart failure, provided they have adequate renal function. SGLT2 inhibitors reduce hospitalizations for heart failure by approximately 30 to 40% in patients with diabetes who are already using evidence-based cardiovascular medications, including statins and blood pressure therapy. Clinical trials with heart failure outcomes as primary endpoint in patients with or without type 2 diabetes are ongoing and may influence future guideline-based treatment recommendations for these patients, regardless whether they have diabetes. Thank you very much.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ZAZ860. This activity is supported by an independent educational grant from AstraZeneca LP.